Abhirath, we will start now. Are you ready? Abhirath, are you online?
Yes, sir. Yes, sir. I am on.
Yeah. I will inform. Once it is live, we will inform.
Okay, sir. Okay. I am connecting my laptop also. I am connected with my phone now.
Hello. Hello.
Yes, yes. Yes, brother. Tell me.
Hello, Abhirath. You can on your video. We'll start now.
Yes, sir. Yes, sir.
Sir, start presentation. Start the presentation.
Okay. Respected Principal Shabre, sir. All the senior lecturers over there.
Who is speaking?
ಸ್ವಲ್ಪ ಡಿಲೇ ಇದೆ ಸರ್.
Are you able to hear me?
ಕನೆಕ್ಟ್ ಆಗಿದ್ರು ಅಲ್ಲ ಅವಾಗ ಏನು ತೆಗೆದ್ರು
No, no, no. ಅದ್ಲೇ ಅದರಿಂದ ಯೂಟ್ಯೂಬ್ ಇಂದ ನಂಗೆ ಬೇಕು. ಇಲ್ಲಿಂದ ಅಪ್ಲೋಡ್ ಮಾಡ್ತಾರೆ.
Are you able to hear me? Can you hear me now? Hello? Hello, can you hear me? Hello? Can you hear me now? Hmm. Am I audible now?
Hello, sir. Yes.
Can I start? Can I start? Can I start? You are able to hear me now? So okay now? Can I start?
Hello. Hello. Hello.
YouTube live ಒಬ್ಬ ಸ್ಟಾಪ್ ಮಾಡಿ
Hello. Hello.
YouTube live ಸ್ಟಾಪ್ ಇಲ್ಲ ಬೇಡ YouTube ಬೇಡ
Hello.
now we start yes
Hello. 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 Hello.
Hello.
Hello, sir.
Amit, unmute yourself and start.
Yes, sir. Okay. My video is not visible, right?
Yes, sir. We can hear you.
No, you can see me or not?
No, we can't see you, sir.
Okay, fine. I'll stop. I'll start the class. Later, I'll join in my phone regarding this. Okay. Okay. Can see my screen now.
Yes, visible. Go to desktop, open PPT. Sir, open PPT, it will be visible. Your browser is visible, not PPT.
Hello.
Hello.
Hello, sir.
Yeah.
Can you hear me?
Yes, yes. Everything is fine now?
Hello, sir. Can you hear me?
Yes, yes, I can hear you.
I can't hear you.
Can you hear me? Hello, can you hear me?
Hello. Hello, sir.
ഏ എടി അവിടുത്തെ മൈക്ക് കൂട്ടി വെക്ക്. Hello, can you hear me? Yeah, I can hear.
Hello. Hello, sir. Can you hear me?
Yes, yes, I can hear you.
Hello.
Hello, I can hear you, brother.
Okay, sir. Just 2 minutes, sir.
Okay.
ಕೇಳಿಸ್ತಾ ಇದೆ ಅದು ಆನ್ ಮಾಡಕ್ಕೆ ಇವರೆಲ್ಲ ಹೋಗ್ಬೇಕು ಪ್ರಾಜೆಕ್ಟ್ ಆನ್ ಅದು ಆನ್ ಇದೆ ಪ್ರೊಜೆಕ್ಟರ್ ಇಸ್ ಆನ್ ಸೌಂಡ್ ಇಸ್
Sound is okay?
ಹೊಡಿಯೋದು
Am I audible?
ಹಲೋ ಸರ್
Am I audible? Hello.
ಎಸ್ ಸರ್ ವಿ ಕ್ಯಾನ್ ಹಿಯರ್ ಯು
Okay. Can I start? Can I start? Hello. തകർക്കടോ.
Hello, sir. Hello.
Hello, can you hear me?
Hello.
Can you hear me, brother?
Hello, sir.
Yes, can you hear me?
Yes, sir. Just 2 minutes. We will start.
Yeah. Yeah, sure.
Hello.
Yes,
Hello.
brother. Yeah. Can you hear me?
Hello.
Yes,
Hello.
brother. Can you hear me?
Hello.
Yes, brother. Can you hear me?
Hello.
Yes. Can you hear me, brother? Can you hear me?
Hello.
Yes, brother. Can you hear?
Sir, can you speak?
Yes. I am speaking only. Can you increase your voices?
Speak.
Hello. Can you hear? Can you hear?
I can hear. ಕೇಬಲ್ ಒಂದು ನಿಮಿಷ ಬೇಡ ಬೇಡ ಹಲೋ
Hello, brother. Can you hear me?
ಐ ಕ್ಯಾನ್ ಹಿಯರ್
Okay. Just can you increase the volume a little bit? Maybe that might be the reason.
Hello. 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 ಕೇಳಿಸ್ತಾ ಇದೆಯಲ್ಲ? You can hear my voice? Hello. Hello. ಅದು ಸುರೇಶ್ ಸರ್ ಅಲ್ಲಿ ಇಷ್ಟನಾ? ಹಲೋ. 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 ಸ್ಪೀಕರ್ ವಾಯ್ಸ್ ಜಾಸ್ತಿ ಮಾಡಿಲ್ಲ ಕಾಲಿಂಗ್. ಹಲೋ. ಹಲೋ. ಕೇಳ್ತಿದಲ್ಲ? ಹಲೋ. Sir, you can start. Shall I tell you? Hello, sir. Can you speak?
Yes, brother. Can you hear me? Can you hear me? Hello?
Little louder, sir.
Can you hear me, brother? Can you hear me?
Yes, sir. Yes, sir. We can hear you.
Okay. Okay, I am ready here. You can tell me whenever you're starting.
Yes, sir.
Okay?
We can hear you. Just 1 minute. We'll start with start the presentation.
Okay. Sure. Brother, hello? Hello?
Yes.
Brother, can you increase your volume little? I think it's too much low. From the PC you are doing, can you please increase the volume?
Yes, sir. 1 minute, sir. We will start within a minute, sir.
Okay.
Hello, sir. We are ready, sir. You can start.
You can start.
Chris,
Yes, sir.
Hello.
Start now.
Increase the piece.
Hello. Can you hear me now? Okay, let's
Yes, sir.
start. Let's start the session. I'm so sorry for all the inconvenience caused and making you wait for your lunch a lot. So without wasting time, I am starting my session. I actually was desperate to do this session because I feel like even from the freshers itself, there are things to be known to you when you are coming out of the college with a degree. So I believe this session will help you in every aspects, like going through the college life and even after coming out of a college. So let's start. The topic I was allotted was the impact of clinical pharmacist in healthcare management. So in this session, I'll be talking more about who is a clinical pharmacist and what impact does he have on a healthcare setting. Please move to the next slide. Can you please move to the next slide? Okay, so who is a clinical pharmacist? I am sure the freshers will be in more doubt to know what is a clinical pharmacist. And even I am doubtful if the 6th years also will be knowing what a clinical pharmacist will do. So who is a clinical pharmacist? Next slide, please. So according to American College of Clinical Pharmacy, a clinical pharmacist is someone who directly work with the physicians and other healthcare professionals and patients to ensure that the medications prescribed for the patient contribute to the best possible healthcare outcome. What does it imply? What does it imply? Like everybody will be having a doubt. What is the difference between a clinical pharmacist and a normal pharmacist? It is evident from the name itself. Clinical pharmacist. He will be more into clinical aspects. the pharmacist will be more linked with the patients. So for bringing about the best healthcare outcome, the clinical pharmacist can't alone do anything. So he needs the inputs from the physicians, other healthcare professionals, meaning like nurses, it may be, maybe laboratory technicians and other diagnostic tools like which one? CT scans, X-rays. These all culminate to make a decision for a patient. So clinical pharmacist will be directly in relation with the physicians and other healthcare professionals to give the best possible healthcare outcomes. Next slide, please. Can you please show the next slide? Yes. Before that, I'll tell you, I will really recommend you to be in this session, because if you, there are many things you should know when you are during the study process and even after coming out with a degree. Because even I and my most of the friends were got humiliated just by saying, hey, you don't know this thing, you don't know this thing. That will be a burden on your head and you will feel like, what I had studied. Actually, what the theories you will study becomes just 50% of what it will be applicable. So please be in the session, because we'll be going through some practical examples also, which you should be learning and practicing from second year itself, because you'll be going to hospital visit for second year. So what and all you should be looking at, what and all you should be bothered about, everything I am telling. So this will help you very, very well. So what impact do they make on a healthcare management? This question can be rephrased as, why you are being hired? Why do a clinical pharmacist be hired in a hospital? Why? The only answer I can tell you is, next slide, please. It is safety. This word I had coined here because I feel that a clinical pharmacist is being recruited in a hospital just to improve the safety while giving a medicine to a patient. So why I coined the name safety? Because patient safety is very important. What and all safety is being handled by a clinical pharmacist. Just think of a situation where a patient is getting admitted to a hospital, and the patient came with maybe a fever or something. And after a lot of investigations, patient was suspected with some infection. So patient will be obviously started with a antibiotic, right? So there are some antibiotics which are heavily excreted which are heavily excreted through kidneys. So what happens is, like, whenever the kidney function is less for a patient, there needs adjustment of the dose such that the kidney is not prone to more damage. But just think of a situation where these things are not being known to you, and you are giving a patient with a low kidney function a higher dose of an antibiotic. The patient will be about to discharge. But what we did, actually we, now the echo is over. I think I have to adjust everything now. The audio is fine. Okay. Previous slide, please. Previous slide. Okay, thank you. So what we did, the patient, we are more making the patient vulnerable to hospital stay, right? Think of a situation where this patient is about to discharge. The patient is maybe discharging after tomorrow he is getting discharged. But we gave him a medicine which is excreted mainly through the kidneys, and the drug metabolites got accumulated in the kidneys, and there is an organ damage for the kidney. What happens? This patient will show more signs and symptoms, meaning that the patient is getting sick more, right? So what happens actually? The patient have to stay more in the hospital again. So if we have done the patient safety parameters correctly, the patient won't have to stay again in the hospital, right? So there is a financial safety also. Whenever there is a patient in the hospital, he have to pay a lot of money. But our duty, what it is, we have to cure with the easiest and the most reliable and fast method, such that the patient's financial safety is also being addressed. So it is very important that patient safety is being made good. Okay. So financial safety is not only for the patient, it is also for the institution also, because just imagine a situation where the patient is given with some medicines and some ADR, some more sentinel elements. Maybe patient got more problematic with this disease, and the bystanders get to know that this is caused by the problems which is done by the hospital authority. They can go for a case, right? Then in my experience, I have one of my colleague who's in his hospital. What happened is like some medication or something happened, and one patient got into coma. So the bystanders got to know that the patient got to coma because of the things done by the hospital authority, maybe some medication or something. And the court made a verdict that till the patient gets okay or till the patient dies, the institution should pay them the whatever for the treatment, whatever for anything. Okay. So the financial safety is not only for the patient, it's also for the institution as well. Please, next slide. So this is the actual thing. Like, if you ask me what impact a clinical pharmacist, what I had did when I was working as a clinical pharmacist, I will surely tell the word safety only. Okay. So that is the impact what a clinical pharmacist do in a healthcare setting. So now what we are going to discuss is about how this patient safety is being managed, or what the clinical pharmacist contribute, or what are the methods these clinical pharmacists will be using to implement the patient safety. First thing is medication management. Then we'll support the clinical decision making. Then antimicrobial stewardship. Then quality improvement, patient education, like that. So these are all, even more we are doing, but whatever came into my mind, whichever I feel like it is too important to tell you, that only I had mentioned here. Please go to the next slide. So medication management. Medication management, if I tell you, is a very vast topic, but it's very important also. So you may have heard about your nearby hospitals. They'll be having accreditations like NABH, JCI. What these are? What are these accreditations? These accreditations say that that hospital is going through some guidelines. What it means the whatever processes happening in the hospital have some guidelines such that the patient safety is being validated. Right. So where I was working, we had NABH and we also had the ISO also. We are probably going through JCA. Now, where I am working now here in Dubai, that our hospital has JCA accreditation. So what it means, we are giving prime importance to patient safety. Okay. Please, next slide. So what is medication management? Medication management involves the comprehensive approach to ensure the patient receives the most appropriate medications. Okay, how can it be achieved? There are actually, it is quite debatable regarding the R's. Like if you search in the Google, you will find 6 R, 7 R, 10 R's, everything. But at least these 7 R's should be maintained, like right patient, right drug, right dose, right time, right route, right reason, and right documentation is very important to ensure that the medication management is carried out in a smooth way. Next slide, please. So what is the workflow of medication management? So everybody will be wondering what is there in this workflow and all. We get the medicine, we give it to the patient. That's it, right? No. Actually, there is a workflow for the medication management. Why it is important? Because it is not about giving a medicine to a patient. Where does this medicine come? Is it what doing what it is about to do? Like if you are giving paracetamol, you think, if I give this medicine, does the thing which I gave act like paracetamol? That is important, right? Next slide, please. So a clinical pharmacist will interfere in every step where the medication is being used. Actually, it starts from procurement step, like from where this medicine is coming. That is very important, right? I'll tell you about this in the coming slides. So clinical pharmacist will be intervening in every steps from procurement till it reaches the patient, and even after the patient is administered with the drug. So the workflow of medication management involves procurement, storage, prescribing and administration, and monitoring. Next slide, please. So procurement process, right? So what do you mean by procurement? You have to get the medicine from somewhere. You can't go like somewhere. You can't go to this shop, that shop, nothing like that. It has a process, right? So we'll be looking about how does this happen, why it is important, what is the CP's input in it. Next slide, please. So I think the third years will be, from the third years, they will be knowing about pharmacy and therapeutic committee, right? What is a pharmacy and therapeutic committee? For the freshers, I will be just explaining a little about it. So in a hospital, there will be a lot of committees being held monthly, maybe weekly also they will be doing, but like pharmacy and therapeutic committee, infection control committee, quality committee, there will be a lot of committees, but a committee which is which deals with everything related to medicine, that is called as pharmacy and therapeutic committee. So a pharmacy and therapeutic committee is responsible for all matters related to the use of medications in the institution, including the development and maintenance of the formulary. I think you all know what a formulary is, right? So for a formulary is a list of drugs which is there in a hospital. So what this pharmacy and therapeutic committee constitute? In a pharmacy and therapeutic committee, there will be a chairperson, a secretary, who will be secretary will be leading all these meetings and all, making the minutes, everything he'll be doing. He'll be other one is the chairperson who will decide what to do, what and all to do, and there will be many members from different departments. Like the pharmacy manager will be there, their pulmonology department, pediatric department, because every department will have different medicines, right? So they need a representative such that any new decisions are being made in front of them. Next slide, please. So in a pharmacy and therapeutic committee meeting, when the meeting will be starting, the meeting will be started with the points of previous meeting. Why there is a point, previous meeting points to be discussed? Because last time, just imagine you are in the meeting, one doctor is raising a point that I want this medicine, or last time for one patient, they gave a wrong drug, this and that happened to the patient, right? These are all complaints. So what we did to rectify it, what all new things we are doing, or what all problems arised in the last meeting is being rectified by this meeting. That and all will be discussed. So next thing is new guidelines and new medicines. Why this point is being included? New guidelines and new medicines means you all know that our science is developing like anything. Every day, someday you will see one drug and then the next day it's banned and next new drug comes, right? Even I can give you an example of COVID treatment. You all might have seen when COVID first hit our all the places, we were not knowing what it is to be treated with, right? So we started giving vitamin C. Okay, you have to improve the immunity. Then you have to have some what paracetamol so that your fever is gone down. But later, after some time, their changes came. Like they started to new guidelines came. They incorporated use of corticosteroids such that the patient is getting better, right? So new guidelines will be coming like with studies and all. So after corticosteroids, they ended up in antiviral therapy like remdesivir. Those who followed up regarding the therapy of COVID-19 will be knowing about it. Remdesivir tablets, 800 mg. We used to give. I was also working when COVID was hit in our area, and even I saw many COVID cases. Later, what happened? Later, it turned into tocilizumab. Right, tocilizumab is an immunosuppressant. It should be used like 9 to 14 days of the treatment such that COVID virus don't get replicated. So these are new guidelines. How come like we just go and do things? It's not possible because it's patient's life, right? We can't just go give the medicine just like I think this will work, this will work. That will not work. There should be proper guidelines for that. So this will be raised in a meeting that like this thing is working. So we should implement this. So it is made available in the pharmacy so that you can use it. New brands mean, like for the treatment, new drugs will be added up. So what the medical representative will be coming, sir, this is a new drug which is very important and it's curing many diseases and all like that. They will tell. So the doctor will be thinking, yeah, it's fine, it's good, and it's cheap as well. so it's better to replace with the other drug. So they will raise a ticket. Okay, it will come to the pharmacy, then we'll discuss in the therapeutic committee, such that that also is included in the drug formulary. That is why the point maintaining of drug formulary is added. And other drug related issues also. Let me just tell you about drug recall. Like, think of a situation in a hospital, in a ward, a patient is being given with a medicine, an injection, like it's a clear vial or clear ampule. Nurse was about to administer it. She just opened it. Then she came to know that the ampule is having some color changes or even some particle or something. So what they'll do, they'll just inform it to the clinical pharmacist that like this happened. Then we'll check that. And if it is a manufacturer defect, we will recall it. Meaning we will send information to the nursing supervisor that you have to take all this medicine with this batch number, such that the medicine is recalled and it will not cause any harm to any patient, right? So think that this happened. Think that this thing is happening. So it will be informed in the committee that this color change was seen in this ampule, and what we did is like we recalled it. These are other related issues which should be discussed in the committee. Okay, please, next slide, please. So what a CP will do, CP will be in the therapeutic committee, at least one clinical pharmacist or all of them in our place, all of the clinical pharmacists were a part of this pharmacy and therapeutic committee. And what we did is like, if a doctor comes with the guidelines that this can be done so that the patient will get better more, we can't trust it. Just blindly, we can't trust it. So what we'll do is like, we take the document, we read it, we undergo proper literature reviews. And even while taking a tablet, I told you that the sales representative will be coming and telling this is new brand, this is cheap, this is, how can we get into the decision that this tablet is working? Just see this paper cutting. In Telangana, what they see, some brands are just giving chalk powder. So it does not serve the need for what it is intended for, right? So there needs to be proper checking from the procurement process itself, such that the patient is not harmed. The patient safety is always handled well. So the CPs help in procurement process as well. Next slide, please. So next thing is storage. Why storage is very important? Storage is very important. We don't even during our studies, we don't care about the storage. We'll study like it will be stored in fridge, but nothing like it is very important, because specific storage conditions are there for different medications. It will be different, like depending on pharmaceutical parameters as well as pharmacological parameters. Next slide, please. So depending on pharmaceutical parameters. So what about pharmaceutical parameters? It is regarding the drugs, pharmaceutical constitutions, right? Temperature sensitive and medication, fridge medications. Let me tell you something, like temperature sensitive in the sense the medicine should be stored in the fridge, right? Just think of a situation where if you have a baby, you take the baby for immunization, right? So all the vaccines will be kept, most of the vaccines will be kept inside the fridge. Just think of a situation where the fridge was not working. The vaccines, the constitution, everything will be gone, right? If the patient is given with some vaccine, just imagine everything, the active constituent is gone. You will be thinking that I had put vaccine on my baby, so he will be having immunity. right? But actually, if it's not working, will it produce any immunity in the baby? No. This will happen. This will happen for sure. Even just think if you fell in the road and you got a crack on your on your hand, you took a tetanus toxoid vaccine to prevent tetanus infection. But the vaccine is just water. What protection do you get? Nothing. So temperature, there are certain temperature in which the things are to be stored such that it retains the pharmaceutical things, the pharmaceutical property. Okay, so the lice sensitive drugs, there are some drugs like ranitidine, then salbutamol, ipratropium. These are all inhalations. Ranitidine is this thing uh, to reduce the acidity. So why this is to be protected? Same thing, the pharmaceutical property is maintained only if it is stored in a best storage condition. So these things are being protected with a blister packet or something. Like the storage condition should be maintained. And I just told you about what medication recall, right? So one day what happened is like I got a call from ER when I was in Baby Memorial Hospital. I got a call from ER and a nurse showed me one mannitol. Mannitol will be like NS and all bottles will be there. Been like, so what happened is I could see crystal formed inside the mannitol. So I thought, okay, actually what we see, any problem in the thing, we will go for a recall. Then I took it to the pharmacy manager and told, sir, I think the batch is full of crystals. There is a problem in the bag, I feel. Then I came to know that there are things that are kept in the warmer. Actually, what mannitol is like, if mannitol is kept in a cold condition, it will form crystals. So mannitol will be kept always in a warmer, always in the sense before using in a warmer, such that crystallization will not happen. So I thought it is a manufacturing defect. Then luckily I didn't go tell any others. So got to knew about this thing very lately. So there are things to be kept in the warmers as well. Please, next slide, please. So according to pharmacological parameters, there are many classifications, but I'll be going through this only. High alert medications. High alert medications are the medications which have the therapeutic window is very low, right? The dose for action and dose to reach the toxicity is very low. So a small increase in the dose can hamper and create problems for the patient. So these drugs are to be managed with the utmost care, right? So what we will do, this high alert medication storage is like the high alert medicines will be sticked with a red sticker such that we know that this is high alert, and it will be kept in separate trays such that we come to know like if a little of the dose is increased, the patient may get harm. Okay, the examples are adrenaline, noradrenaline, insulin, like that, dopamine, dopamine, everything. Okay, then coming to LASA drugs, lookalike and like you will be knowing about it. You must have studied about it also. I'm more not going into detail, but what I will be telling you is like lookalike. Lookalike will be like same thing. Okay, so different hospitals will be having different policies, but for lookalike we will be usually sticking yellow color stickers so that we get to know that there is one more medicine same like that, and maybe the action will be different. So care should be taken before administering it. So that storage is also important. Then sound alike. The doctor says give him dobutamine. We hear it is dopamine. Action is different. So it will be colored into different color, like green color. We'll be storing it separate so that there is an alternative also, and the action will be different. Okay. Then high concentration medication. And one more thing I have to tell you is that please read about fluids. There are a lot of fluids being used in hospital. There are like dextrose 5%, dextrose 10%, DNS, RL, NS, half NS, hyper saline, that is 3% saline. Why this is important? Because there are these medicines are when we prescribe a medicine, these are medicines are even diluted in different solvents. So it is very important to know what and all is used for specific therapies. Then coming to controlled and narcotics, these are actually, you know, about narcotic is a dirty crime. So narcotic and controlled medicines have to be regulated, like it can cause addiction. So even the government will be looking about into it. We'll be having, even for narcotics, what we have, double lock and key will be there, so that there is no illicit things happening. And even we have a separate book which will be having which date it is prescribed, who prescribed, which patient, which patient it is prescribed, with how much dose, how many ml it is used, what is the balance, what they did to the balance medicine. This and all will be there in the narcotic register. So this will be also stored in separate so that nothing happens, like people won't get addicted or people don't steal the drugs. Okay, next slide please. Okay, so how this storage you can you know, maintain? Because like if you go and tell for one day, it will not be you know, followed for the rest of the days. So proper audit should be there, like in a week or in a month, everywhere it should, you should go. Like, you also know that the medicines are also stored in the wards, like in a ward they'll be having a little of some life-saving medicines or which is needed very fast. So there is no delay for giving it to patient. Like just imagine a situation where a patient is being admitted, and suddenly the patient got nausea and he started vomiting. So the patient is to be given with the ondansetron injection, right? But think of a situation, the patient is vomiting and we are calling, hello, pharmacy, give me one ondansetron injection, which is where the pharmacy is in the next block. By the time he reaches, this guy will be dying, vomiting, right? So certain medicines will be kept in certain quantities in the wards also. So that storage also we should check whether the medicines are not expired, the medicines are the quantities are the same. So proper audit should be there. And just see this picture. I don't know many of them had seen or not. These are called crash cards. Why this thing is called crash card? It is called crash card because crash means, you know, something is damaged or something is falling or something, right? So this is very useful when a patient crashes. Maybe the patient suddenly got a heart attack. He fell down with in a heart attack. What you will do? You can't like take the patient and carry him till there. By the time he will be dead, right? So this crash cart will be having many medicines, life-saving medicines that can be used in in a matter of second, like pre-filled syringes. We don't have to just put open the ampules and all. It's already pre-filled. If you want to just put it, just hit it on his chest, adrenaline will be released, so that uh, fastly the patient could be recovered, right? So in this crash cart, there will be medicines as well, and even many things that like suction catheters, a feeding tube, oxygen mask, many things will be there. So this should be also audited every month, such that there is things are like, just imagine a situation, patient is about to die, when you check the crash cart, there is no adrenaline. It's a horrible situation. It's a real horrible situation, right? So it should be audited monthly such that people come to know that you come to know there is nothing missing there. Okay, life is very important, so it's important to audit this as well. Please, next slide, please. So how they help in clinical decision support? How this clinical pharmacist will be helping in decision support? I think what we do as a clinical pharmacist is error reduction. We are all humans. We all do humanly errors, right? So where and all these clinical pharmacists interfere? Usually the process is prescribing, administering, monitoring. Where and all these clinical pharmacists interfere? Every step. Before prescribing, after prescribing, before administration, and after during the monitoring session also. How it is like prescribing before prescribing, how it happens? Actually, when I was working in Baby Memorial Hospital, I was in the ICU, critical care ICU. Usually we have rounds in the ICU at 9 o'clock. So we'll be going every bedside. The patient will be there. Patient's conditions will be there. Suddenly, if any query arises for the doctor, what dose you will give for this patient? They'll be asking us, right? What dose you are about to go to give the patient. So we have to do this so that the error, what the doctor will be bluffing, is not happening. Like just imagine the doctor is writing something which is not the correct way. The patient will be harmed. So proper inputs from the clinical pharmacist will be there before prescribing as well. So just imagine the doctor already prescribed the medicine. Doctor prescribed the medicine. Then we went there and we checked there is some problem in it. Then we interfere. Then we tell the doctor, okay, so doctor, there is a problem in this dose can't be given. Then there is a implementation of more patient safety there. Even after administration also, there will be having monitoring things. I'll be going through that also in the coming slides. Next slide, please. So how this happens, how this process happens is by medication review. Medication review is not only about checking the medicines. If you want to check the medicines and check the medicine is rational or not, you need to know what the patient is having, right? What the patient has, what condition does the patient have. So there is a need to read the patient file. So all the information regarding the things of a patient will be in the patient file. So in the patient file, you will see patient demographic features, allergic status, lab investigations, diagnosis, treatment chart, and monitoring chart. Next slide, please. So we'll just go brief into all these things. Okay. So patient's demographic features. Actually, age, gender, subjective evidence, these all have a big part in clinical decision making. Age, you always know, like depending on the age, the dose varies. The dose of a pediatric doesn't work for a geriatric patient. So it is very important to understand the dose of a patient. Second is gender. Gender is very important, and you should correlate their disease with gender. Why? I'll tell you, I had a very bitter experience when I was in fifth year. That was my last presentation, I think. Then, so I started, even my juniors were there sitting in front of me to see the presentation. I have Adindra sir and Abhishek sir for assessing it. So I started the presentation telling, okay, a 35-year-old female patient came with a so and so complaints and this thing and that thing all. Suddenly, I ran into the social history of the patient, and it was saying 10 packs of cigarette daily. Suddenly, everybody was shouting, 10 packs of cigarette. Sir, this what she is telling. But what happened? Aditya sir and Abhishek sir told, why even now girls also smoke? There is nothing with that. Then I was like, oh, I got saved. But the real fun happened when it went to the diagnosis. I read other things, and I reached the diagnosis, and the diagnosis was waning prostatic hypertrophy. Then the fun happened. Actually, the females will not have prostate gland. What mistake I did was I just went on reading this. I didn't focus on the patient is male or female. Like maybe I typed it wrong, but it is very different, and you can't imagine what blunder I did. And I was about to do the presentation again. So careful about this thing. You can't diagnose a male patient with PCOD. Okay, like that. Okay. So the subjective evidence and this point, subjective evidence will be saying the patient has this and this, and the patient is conscious and oriented. Usually, you will say everybody in their PPTs they will write patient is conscious and oriented. How you assess? Ever did you check GCS, Glasgow Coma Scale, or many other scales are there to assess the patient consciousness? It's based on that only the consciousness is being assessed. um, our lecturers, please keep a note of this and let our, I think in the syllabus it's there, I had read it somewhere. Please let them know about Glasgow's coma scale. Okay. Then the past medical history, the patient, what the patient was having, any disease, or that is very important. Then past medication history, at least from the medicines, we can make out the patient was having, what disease the patient was having. Then the social and family history, what the patient family has anyway, some diseases are genetically transferred to the child as well. So that also you can see. Next slide, please. Okay. So I'll be making it fast now from now. Okay. So coming to the allergic status, I'll just go through. Already Salman have told you more about this. So ADR, anyway, he explained you understanding of various scales. You know the various scales are there. Importance of ADR reporting, that also he must have told you. Then the other thing is how important is finding a proper ADR, right? This is the point what I wanted to stress on more, because when I was in Baby Memorial Hospital, there one patient came with a dermatological admission was there. The patient was having pain all over the body. The patient was met with an accident, and the patient was given with amoxicillin and diclofenac. Then I was assigned to just assess the what will be the ADR. Then suddenly I checked it. There are chances of this same condition if you are taking amoxicillin. So I wrote the I took the WHO scale, Narinjo scale, and I completed everything. Then I took it to the doctor. Then he told me, what foolishness you are doing, because you are just running blindly into the conclusion that amoxicillin is the thing. He asked me to go again to get the this thing, full history of the patient again. That time patient had same episode some months before when he was taking the same medicine. And luckily, it was amoxicillin and clavulanic acid itself that has caused this problem, serum sickness like problem. But just think of the situation, both drugs are also there. Amoxicillin is there, diclofenac is there, both situations there. The patient recalls that last time when I had pain, I had took the diclofenac, then also it occurred. Right, I was just jumping into amoxicillin and clavulanic acid. I didn't check for diclofenac. So what happened? Just imagine if I told amoxicillin, then amoxicillin is written in the ADR. Amoxicillins are basic antibiotics. Once the ADR is written, they will not never use it in their life, right? So they have to use more severe, more potent antibiotics, which will create resistance, right? You will be knowing about it. So finding the proper ADR is very important. Next slide, please. So investigations, understanding various biomarkers correlating to the diagnosis and reference ranges. Nowadays, reference ranges is not a big deal because anywhere the reference ranges will be there at least in the side so that you can correlate. Understanding various biomarkers. There are various biomarkers for different diseases and different conditions. I will just give you one more example. One patient was admitted in a hospital in the ICU, and patient was having a little fever only, but patient was on fluids, patient was on adrenaline or adrenaline, patient had chances of septic shock as well. There is no chance of bacteremia in his uh, from the peripheral this thing. So then I asked with my doctor, sir, how did you came into the conclusion that it is sepsis? Then he told me the procalcitonin levels are high. Procalcitonin, I didn't knew about it. I didn't even knew about that in the initial stage of bacteremia. Procalcitonin will be high even if other things are not there, other lab investigations are not there. So like that, even now when the COVID is causing any heart attacks and all, you must be hearing about D-dimer test. Checking if there is a chance of getting clots, right? So there are many biomarkers they should be in your mind. Okay, making it fast to complete it. These all should be known. Next slide, please. So diagnosis in the sense diagnosis should be supported with the signs and symptoms, lab investigations, and other diagnostic tools. So you can't diagnose a patient having sneezing or wheezing with a migraine, right? It should be something related to drug. So it should be supported with the signs and symptoms. The next thing is lab investigations. Investigation in the sense, as I told you, there are patients are having chance of getting clotted. Their DMR will be increased. That's for sure. It should be supported. The diagnosis should be supported that. And the other thing I wanted to tell the lecturers who are now there to please give basic idea about these diagnostic tools, X-rays, MRI, CT, what and all. Reading it. Like what happens is like most of the PPTs what I see of new students, there will be saying in the X-ray there was pneumothorax or consultations, something like that, but they didn't see this X-ray. They can't make out. If we give them X-ray also, they can't make out the patient is having consultation. Nothing they can't make out. Even I can't make out that time. Now I have a little idea. And even the MRIs or CT, MRIs or CT also, when I was in the neurology department, I saw many CT of the brain where there is a stroke or any this thing. So I could make out like white color is happening this side. So which and all activities will be less. So please give a basic idea about X-ray, CT to the even from the second year. I beg you to make them aware of all these things because I didn't knew, and I believe if I got if I knew it from that time I would be something great now. Please make a note of it and try to let them know about even ECG also. Easy. Okay, I'll stop it sometime. Okay, so it should be there. Okay, next slide, please. So treatment chart is where we find all the errors, and treatment chart will be varying from place to places, and the treatment chart will be having start orders, regular orders, and infusions as well. So a start order means that it should be given like suddenly. The regular orders will be the patient will be having which or medicines will be given regularly, and infusions will be calculated depending on the patient's needs. Next slide, please. And treatment chart. Coming to the treatment chart, every parameters of the treatment chart is important, and there is need to find the errors in the treatment chart. That is our prime duty being a clinical pharmacist. There are many parameters. I'll be explaining it fast. Next slide, please. Mainly the medication error. Medication error means any error happening depending on the medicines comes under medication error, and this is the definition given by the NCCMERP. So medication error finding is the prime job of clinical pharmacist. Next slide, please. there are many types of medication errors. I'll not go deep into it. You can read it later. But what you should know is medication errors are classified in different categories depending on the extent it makes harm to the patient. So there is classified as A, B, C, D, F, G, like that you will be doing once you are getting into a job. Next slide, please. So drug name, why the drug name is important? To understand the drug is correct or not. In some this thing will be seeing things which come ends with sol will be PPIs, but it's not always right, because pantoprazole is there, carbamazole is there, both ends with sol, but they have different actions, right? Then understanding sustained release, extended release, double strength and all. What happens is like these extended release are having more amount of drug, so they are given once in a day, that the activity is completed. But what happens is like the doctor will not be aware of this. Doctor will be doing it twice a day or thrice a day for the extra. The patient will be in huge mess after having that in T2, BD or TID. And even there are chances that they cut it. What is the point in cutting this XR tablets? It's a medication error where you cut half tablet of SR tablet. It's a medication error. And also the verification of duplication. The patient came with a fever. The patient has even pain also. The patient is prescribed with a paracetamol injection, TID or QID, and also the maxigesic has a combination of paracetamol and ibuprofen. So altogether the paracetamol dose crosses 4 gram. That is a medication error. The patient's hepatic, this thing will be gone. Next slide, please. And coming into dosage and dosage route, this is also important. I'll just tell you about inhalation only, which is very important. What happened in our hospital is that Vendol, that it is salbutamol. Salbutamol we usually give for the usually give 2.5 mg per 2.5 ml. So 1 ml will be given for the children. Later what happened, it again went out of stock. After that we got 20 ml salbutamol, which is 5 mg per ml. So to give 1 mg dose, we have to give just 0.2 ml only. So the dose written was 0.2 ml only. Then what happened when the other Vendolin came into stock? Still there was 0.2 ml only written for the dose, and all the pediatric patients with wheezing and all, they were not even responding to, they were not getting well. Then they came to know that this is the mistake what happened, which caused the patient to not get better. So there we need to think and act regarding this. I have to explain this, but I am constraining it to little words. Dose calculation is very important compare when it is about with the clinical pharmacist. Next slide, please. Dose is dependent on age, weight, renal factors, LFT, liver function test, and various other parameters. I'll be going fast with all this. Next page. So we'll take we need mostly it will be on the weight based calculation. Only for pediatric we need weight and age also. And there should be a standard guidelines for all the dose calculations. You can find it in Lexicon, UpToDate, Medscape and all. Next slide, please. Just think of paracetamol. Paracetamol, the dose what is given orally is for the pediatric is or even the normal dosing is 650 mg every 6th hourly or 4th hourly or 6th hourly. Next point. Oral dose is fine because most of the time the bioavailability will be less than 100. So there is not a problem. But coming to IV, next slide, please. But coming to IV, the dose will be varied. Like just you can see IV less than 50 and greater than 50. Greater than 50, you can give 650 mg every 4th hourly. Otherwise, if the patient has less weight, you should give 12.5 mg per kg every 4th hourly. It should be calculated based on that. So there is a calculation dependent dose determination. Next slide, please. This is all for oral, which is dependent on age as well as the weight of the patient. Next slide, please. So here you can see where in IV cases where this infants and children and adolescents, both everyone is having age as well, and this thing age and weight is the parameters to calculate the dose. Next slide, please. I have to explain actually, but due to time constraints, this is very important regarding the renal function test. Please, from the second year itself, create a culture of understanding the renal function test and adjusting the doses for drugs. I'll be telling you about it. This is mainly dependent on urine output. When the urine output is less, it means the kidney is not working properly. So there is a possibility of accumulation of drug in the kidney. So there needs a decrease in dose such that the patient's kidneys don't get more worsened. Next slide, please. So you all know Cockcroft-Guilt equation will be used to calculate all these parameters. To check the creatinine clearance with which we assess the patient's renal function. Please open your phone and I'll tell you something from the next slide, please. I'm so sorry. Please open your phones also. We used to use this CKD EPA equation as well for dose calculation. Next slide, please. Only 10 more slides, please be patient. 10 more slides, please. Next slide, please. So please open your phone. Just type medicals. Then you will see creatinine with creatinine Cockcroft-Guilt equation. There, this was the main thing I have to discuss you with this thing. Lecturers, please give a note. I can't explain more here. Just now I will be telling a little about it only. So if in a situation like just think if a patient is a female patient, we are giving the age of the patient 40, the weight is 60 kg, and the creatinine clearance is 2.8 mg per dl. Then the result will come as 25 ml per minute. Just think that is 25 ml per minute. Next slide, please. So the usual dose of, if we are taking example of piperacillin tazobactam, the usual dose is 3.375 gram or 4.5 gram every third hourly. Right, that is the usual dose. Next slide. So just think if the patient is coming with a pneumonia. So the usual dose is 4.5 gram every 6th hourly. Just keep in mind 4.5 gram every 6th hourly. Next slide. In case of urinary tract infection, patient is coming with a urinary tract infection. The dose is 3.375 every 6th hourly. This dosing is based on the normal renal function. Okay. Just think about it. Next slide, please. So, but when it come to a reduced renal function, now what we calculated, the creatinine clearance of the patient is just 25. Where it will come 20 to 40 will be the parameter, right? So in the 20 to 40, in the top you can see if the usual recommendation is 3.375 gram every 6th hourly, what is the dose? If it's 4.5 gram every 6th hourly, what is the dose? Right? I think the time allotted is over for me. Okay, thank you. So if the patient came with the pneumonia, you can see 4.5 grams 6th hourly is the normal dose. So when it comes like 20 to 40 mg, the usual dose we can give is 4.5 gram 8th hourly or 3.375 gram every 6th hourly. But if the patient was having a urinary tract infection, the usual recommendation is 3.37 gram 6th hourly. So now what happened? We have to reduce the dose again. So now what is the dose? 2.25 gram 6th hourly. This thing you should follow from second year. I beg you all guys, because you should remember this every time you are going through this. Next slide please. Next slide please. Dose calculation is very important. Even hepatic correction also is there. I am not going to deep things. Next slide. One more thing I have to make important thing is there, that only I'll tell and I'll wind it up. Next slide. This is during the monitoring process. After monitoring things, the dose will be varied. This is not the proper thing, so it's fine. Next slide, please. Loading dose and maintenance dose. At least know there is something like no loading dose and there is something like maintenance dose. Okay, we'll go later. One important thing is coming. Next slide. And start and stop date is important for all these drugs. I'm not explaining why it is. Next slide. And special instructions, actually I wanted to inform more about this, but now not telling, but I'll just tell one small information about vancomycin. You all know about Redman syndrome. It is caused by infusion rate when the rate is more, but now the Redman syndrome is coined again to vancomycin perfusion syndrome or something like that. Just that information. Next slide. This is very important. I may tell you what it is. You should remember this title, global RPH, because any medicine, any injection you are giving into a patient, just type global RPH dilution. Next slide, please. When you type something, anything, any medicine, any medicine, there is a need to understand in which the thing is diluted. Next slide, please. Just this is meropenem. Just see usual diluents D5 or NS. This will vary. So you should, from the second year itself, just please study what it is diluted in or how much time it will take, like 0.5 gram, how it will, in 50 ml NS or D50 you should dilate given in 15 to 30 minutes. Like that 1 gram, 1 gram also is diluted in 50 ml. 15 to 30 minutes it will be given. Which diluents, what is the time it should be given. This site will be very important for you. Global RPH. Please keep a note of it and write about every time you come across an IV thing, just read about it from this site. Next slide. Next slide. This needs more explanation. This also need more explanation. Then antibiotic stewardship. It's a very vast subject. Next slide, please. The antibiotic stewardship is very important for clinical pharmacist and understanding surgical prophylaxis, understanding resistance, importance of culture report and escalation and de-escalation. I'll tell just brief about escalation and de-escalation only. What it is like, many a times we come across a situation where the patient is given with a higher antibiotic, piperacillin tazobactam. Reading the file, we will not understand why this is given. But actually, if the patient has an hospital administration within 90 days of previous 90 days, we can start with a higher antibiotic. Like that, escalation and de-escalation will need a specific thing. Correct thing should be there for doing all these things. So it is very important. Please read about escalation and de-escalation regarding antibiotic stewardship. Next slide. I am not giving explanations more about it. This is a replica of culture report. how the things are, the growth of Haemophilus influenzae, like that we'll get the information. Then only we'll go for all these antibiotics, which antibiotics we are selecting. Next slide. And please read this book. It's very good book, Antibiotic Basics for Clinicians. You will get everything you need about antibiotics. I read this book only. You can get it from setlibrary.to. It is very important. Please read it from second year onwards. You read it, by the end you will be a great master. Next slide. Patient education already, Eldos might have told you about it. So I'm not doing more. Next slide. Quality improvement, the other method of quality improvement, you do all these things, whatever I told, and more we are doing. And all these improves the quality of healthcare, improves the patient safety. And what more you can do to improve the quality of a quality improvement? You can work under the quality department of the hospital and be an internal assessor. I was an internal assessor for NABH. Like that, you can also be, and you can improve the quality of care you are supplying and even the patient safety. Next slide. And the one big thing I have to tell you is that have a habit of improving your connections. Make a best possible LinkedIn profile. You can, if you start it now, you will get a lot of information from that. And next slide, it's thank you. And thank you so much for hearing. I completed my lecture. Thank you so much, everyone, for being patient and hearing all this. Thank you so much, the Indian Pharmaceutical Association, Dakshina Kannada, and Srinivas College of Pharmacy for calling me. Thank you, Sadish sir, Christy, and all the lecturers, junior lecturers out there who are hearing, senior lecturers as well. Thank you so much. Thank you.
Thank you.
Thank you. Thank you. Hello.
Hello.
Yes,
Hello.
yes, 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 sir.
Hello.
Yes, sir. Tell me, sir. Hello.
Hello.
Yes, sir. Tell me.
Professor Hegde speaking. Abit, it was a nice session.
Thank you so
Thank
much,
you
sir.
so
Thank
much for your session from the long distance.
you. It's like a dream come true for me.
Yeah, it was a highly informative session. Okay, you
Thank
can log out from the online mode. Thank you.
Okay, sir. Okay, okay. Thank you so much.
Yeah.
Coming to
Thank
India.
Whenever you come to India, just come to Mangalore, visit our college once again. We'll meet here.
Yeah, sure, sure, sir.
Yes.
Okay, thank you, sir. Bye.
Thank you very much. Yes.